So we will go ahead and begin. So I am Jackie Gillman, and I will be presenting Journal Club today. I'm one of the pediatric interns. So without further ado, the article that I chose to present today is called The Effect of Epicutaneous Immunotherapy versus Placebo on Reaction to Peanut Protein Ingestion Among Children with Peanut Allergy. This is the PEPITES randomized clinical trial with David Flescher et al. I have no conflicts of interest or disclosures to report for this presentation today. So these are just some of the objectives that I have. So I would like to discuss the different modes of current research on treatment of peanut allergies. I'd like to review the definition of confidence interval and its effectiveness in evaluating a research study. And then also analyze the use of epicutaneous treatment in the general population and its utility as a main mode of treatment. So as always, we'd like to start off with the WHO. As you saw at the beginning, there's a significant number of authors who were involved in this study. Two of the main ones were David Flescher and Dr. Wayne Schreffler. So we'll kind of go into detail a little bit about who they are and what they're involved in. So David Flescher, he is a MD. He currently practices at the Children's Hospital of Colorado in Aurora, Colorado. He did a residency in pediatrics at Johns Hopkins. So he's over from our East Coast side. And then fellowship, he also did Johns Hopkins, pediatrics, allergy, and immunology. He has several reported articles that I could find. He has 89 just on PubMed alone. Most of these articles are mainly based on treating peanut allergies and kind of the pathophys of peanut allergies, as well as a couple others, but mainly on the allergies to peanuts. He looked into sublingual trials as well as epicutaneous trials, as well as oral challenges, and we'll talk a little bit more about those later. He did receive some funding and support from some significant places. His big one was the DBV Technologies group, and this is a group that basically believes that there's a cure for allergies and spends a lot of their money on finding cures for allergies. So he was involved with them. And he's also a board member on the National Peanut Board as well. So he has a couple disclosures there. And then this trial itself was also funded by DBV Technologies, and those conducted under the Investigational New Drug Application to the US FDA, and then also had clinical trial approvals in Canada and European countries. And again, we'll talk a little bit more later about how far this trial expanded to. The other one that I wanted to talk about, since there are several authors, these two are kind of the main authors that were present for the study and did the major contributions to it. So Dr. Wayne Schreffler, he currently practices at Mass General for Children. There he is the chief pediatric allergy and immunologist, or he's the chief of pediatric allergy and immunology. And he's also the chief for the Food Allergy Center as well over there. He did his residency at Montefiore Hospital and Medical Center in pediatrics. And then he did his fellowship at Mount Sinai Hospital Medical Center, also in allergy and immunology. In case you haven't sensed the theme here, they're all involved in allergy and immunology. So Schreffler also has a significant number of articles reported. He had about 88 articles from what I found. And his is kind of the same deal. His around the pathophysiology of allergies and treatments for allergies. He did delve a little bit into some of his articles on asthma and treating asthma, as well as eosinophilic esophagitis. So again, they're all allergy and immunology, but he kind of strayed a little bit from that peanut had gone through. So he also received a little bit of funding and support. So he got personal fees and research funding also from DBV Technologies. And then he also got grants from NIH, Sanofi, and Food Allergy Research and Education to fund this study. There are several other authors that had other connections and funding, but I felt like those were kind of the important ones that we needed to go through since they were such major players in this as well. So why should we bother with even researching this? I'm going to go a little bit into some history here from several years ago that's kind of been a change recently. So the big kind of peanut allergy trial that we talk about is the LEAP trial. And I don't remember exactly what it stands for, but basically the scientists noticed that in Israel, kids there had 10 times lower incidence of peanut allergies than their same counterparts in the United Kingdom. Similar descent, but one was brought up in Israel and then one was brought up in United Kingdom. And they kind of looked into it, and from what they found is that these children in Israel started consuming peanut products at a young age. Median age was 7 months, but some even younger than that when they just started doing people food. So this is kind of what brought about the LEAP trial. The LEAP trial was a randomized open label controlled trial. And I just wanted to throw in a picture here. Shout out to Guy Katz, who's one of the peds surgery residents who introduced me to Bamba. But Bamba is the peanut puffs that the babies eat in Israel. And he said that they basically feed them to them as soon as they can start taking anything by mouth. Apparently they taste absolutely delicious. So I just wanted to throw a picture in here that kind of started this trial and why we started looking into it. So we'll just quickly discuss the LEAP trial. So this trial was a large trial of 530 infants, plus 98 other infants. So the 530 infants had an initial negative skin prick test for peanut. And then they had 98 infants with the initial skin prick test that was positive. So after the trial was completed in the peanut allergy avoidance group, so they didn't get any peanut allergy or any peanut products within that first year of life, they developed peanut allergy 13.7% of the infants versus the 1.9% that did not develop or that developed peanut allergy in the consumption group. So in other words, those who had taken peanuts earlier had a less percentage of developing peanut allergies. And then we also had the 98 infants who did have the initial positive skin prick test. 35% of those infants went on to develop allergy in the avoidance group, and then only 10.6% of those infants actually went on to develop peanut allergy in the consumption group. So I'd say that that was like a pretty significant difference in those who initially had a positive skin prick test in those patients. So the conclusion from this trial was that early introduction of peanuts significantly reduced the incidence of peanut allergy in those that are high risk. And I believe it is now an AAP recommendation that we don't withhold peanut products and you can start them earlier now. So Dr. Nguyen and myself had a long conversation about this one day during rounds because I was not, aware of the LEAP trial. So I thought that was really interesting. And that's kind of what brought us to look into the effects of epicutaneous trials as well as the sublingual and the, oh my gosh, the skin pricks as well. So just a little bit as to why. We kind of have already touched on this a little bit, but there's other trials going on for oral therapies and sublingual therapies, and many trials have been done with those, and they're pretty well described. I'm sure that if you guys have, anybody's done like an allergy and immunology rotation, we do use a lot of the oral or sublingual immunotherapies, and they go on for months and months and months. They take a long time. You have to kind of start low and go up very slowly. So the benefit of epicutaneous would allow for avoidance of actually putting oral allergens into your mouth. You can do it from home fairly easily. Better adherence because you just kind of stick on the patch and then call it a day, and you don't have to remember that you need to take any other oral or sublingual therapies throughout the day. And then you also have better adherence, which we just kind of talked about. And then the idea was that you'd have maybe a more favorable adverse effects profile because you're not actually intaking the allergen itself, it's on your skin. So you would have less systemic effects in theory. So these were kind of the reasons that they delved into this and thought that this might be a good research project to follow up with. So with this trial, there has been epicutaneous trials studied before, but those studies had only covered ages 6 to 11 years old. And this trial sought to look at ages 4 to 11 years old, so 2 years younger, so that maybe you could start the trials a little bit younger. And the idea is that you would prevent anaphylactic reaction to something that's contaminated with peanut products. Maybe not eat peanut products completely, but just looking for a treatment that you feel safe if you accidentally eat something that may contain peanut products. So this trial itself was a very, very large trial. They had multiple institutions. They had 31 sites combined in Australia, Canada, Germany, Ireland, and the United States. They have a really wide range of areas and kind of like a broad net to really capture all these places. The places that it took place at, they did them in hospitals. They had research sites in some of these places. And then also a couple allergy clinics were also involved in this study. And then, of course, with all these institutions across the globe, you're going to have several of the authors from these areas as well. So the authors are from all over the place, multiple people involved. So very large scale in this aspect. We'll talk a little bit about the study population that was included. So like I said before, we had it was 4 to 11 years old, and they had to have a physician-diagnosed peanut allergy prior to starting. And then they also had to be following a strict peanut-free diet. The study had a couple of people that were excluded. Those with severe anaphylaxis were considered too high risk to be able to participate in this trial. And the severe anaphylaxis would include those with hypotension in the past that required vasopressors, any hypoxia requiring mechanical ventilation, and then, of course, neurologic compromise. However, those with a more mild anaphylaxis, for example, hives or diarrhea, any combination of those, they were not excluded from this trial. So they were allowed to participate in that as well. But the severe anaphylaxis obviously were too high risk to include in this, so they were not able to participate. The study also excluded those with chronic conditions, specifically asthma, because it is contraindicated to be able to do these studies in poorly controlled asthma. I believe that they did have some asthmatics who were able to participate, but they had to be well-controlled asthma at that point. So here's a table of the kind of demographics of the patients that were, or the participants in this trial. So they tried to organize them equally on both sides. The one thing that we did kind of notice as Dr. Nguyen and I were looking through this is it does have a very heavy Caucasian population and not so much any of the other ethnicities or races. So that's just something that we can talk about a little bit later when analyzing if this is applicable to our own population. They had a significant number of males in the peanut patch group too, which I just want to point out. They had 149 over here versus 69, 49, and 89. So average age or median age was 7, so that kind of falls within that 4 to 11, so good age range there. And then we have our baseline eliciting dose, which we'll talk a little bit more later, but we have a heavier reliance on the 100 to 300 milligram doses versus the 1 milligram to 3 milligram. We had significantly less amount of people that were present. And then down here we have the asthma, eczema, allergic rhinitis, and allergies other than peanut. So as you can see, several of our participants had other comorbidities as well, which we expect because we often see the allergies and the eczema and allergic rhinitis, all those kind of fall together. So it's not completely unheard of for this to be present. All right, so when did this trial take place? The trial ran from January 8th, 2016 to August 18th, 2017. And when we talk about the study design, we'll visit that a little bit more, but the study was a year long and then was not published until March 12th, 2019. So it took that long to kind of gather their data and publish it. So this was within the past 5 years, and usually that's kind of our marker for, is this clinically relevant at this point? So 2019, I guess, is 3 years ago. Can't keep track of what year it is, so it should be relevant at this point. All right, so let's get into a little bit of the nitty-gritty of this this trial. So this was a standardized double-blind placebo-controlled trial with food challenges. So how they determined what group they would fall into corresponded to an entry challenge that they did. So this challenge was basically an oral challenge of peanut protein, and they started with a dose of 1 milligram and would give that to the patient and see if they had any sort of reaction to it. And they would go from 1 milligram to 3 milligrams, 10, 30, 100, and 300, stopping when they reach 300 max dose. So if they had any symptoms prior to 300, they would be put into a different category for that oral challenge versus the 300. The challenges were discontinued when the symptoms were met with pre-specified criteria. And I have a table on the next 2 slides that kind of show what criteria they looked at for this, and then how they kind of scored that. Of note, the itchiness of your mouth and just like itchiness of your skin was not necessarily a reason to stop the trial. For the most part, it was noted in their chart, but they were able to proceed. And it was done with a placebo trial and also a peanut protein trial as well. So if a patient had a reaction in the placebo trial and also the peanut protein trial, they were excluded from the study because it wasn't accurate at that point. So once their oral challenge was completed, they took that and placed the participants into 2 groups. It was either a 10 milligram or less. So if they had a reaction at 1, 3, or 10 milligrams, then they were put in the low eliciting dose group. And then if they had anything greater than 10 milligrams, so that would be 30, 100, or 300 milligrams, they had a reaction, then they'd be put into the high eliciting dose group. So this is kind of a long table. It's 2 slides long, but these were just some of the symptoms that they looked for when they were doing this oral food challenge. And then there was a percentage of the area involved would dictate the scoring. So the things that they looked for were rashes, pruritus, urticaria, and rash. So those were the skin findings that they looked for. And then they also looked at upper respiratory. So sneezing and itching, nasal congestion, rhinorrhea, and laryngeal issues as well. And then we also looked at lower respiratory, which included wheezing, and then GI, which would be subjective complaints. They go into itchy mouth and throat, nausea, abdominal pain, decreased activity, patients in bed, crying, and notably distressed as well. And they also had to take into account the objective complaints. So if they had emesis or diarrhea, those were also taken into account as well. And then cardiovascular and neuro, they looked at color change, whether they were weak or dizzy. They checked on tachycardia, mental status. If they had any hypotension, that was also noted. And then you can see a drop in blood pressure like greater than 20 from baseline or impending doom. So all things that were taken into consideration for the safety of this trial and when they would be at their eliciting dose. So a fun fact, because you're probably wondering where these doses are coming from. So our max dose was 300 milligrams for this oral entry trial. So if you look in peanuts, you have about 250 to 300 milligrams in one peanut. So that max eliciting dose that we were trying to reach is about the same as one peanut, if just to put it into perspective for you guys. So this is the study design that we're looking at. So you had 500 children total. You had 144 that were excluded just due to not meeting criteria, severe reaction during the challenge, adverse events, or they had some anxiety, unlikely to cope with the conditions. So we ended up with 356 that were randomized into 2 groups. It was a 2-to-1 randomization, 2 being the treatment and 1 being the placebo. They had 238 in the randomized peanut patch and then 118 in the placebo patch. Of the 238 in the peanut patch, 213 completed the study. Most of the withdrawals were due to withdrawal of consent, and there were 4 adverse events that led to withdrawal. And then of the 118 that were randomized to the placebo patch, 107 completed that trial. Again, the highest being withdrawal of consent, and then we have loss to follow-up as the next most common. So what I said before, that you have that 2-to-1 randomization to the treatment versus the placebo group. And then each group received patches, and then the patch for the peanut group had 250 micrograms of peanut protein in the patch. And then the placebo obviously did not have it. So to start this, they did it under doctor supervision. The first patch was placed for 3 hours, and then if they didn't have any severe reactions, they were able to move to the next one. And so the daily patch time that they wore the patch increased to 6 hours per day during week 1, and then 12 hours per day for week 2. And then finally by week 3, we reached our max of 24 hours per day. And then each of these groups wore that patch for 12 months. So long time of wearing the patch. Yeah, so we'll go from there. So this is just a figure of where the patches were placed, and what they would do is alternate where the patch would be placed each day. So like day 1 would be at the scapula border on the left, and so on and so forth, following the numbers, and then just rotating through there. This was to help prevent any breakdown of the skin, because as you know, if you wear a Band-Aid for a long period of time, your skin gets kind of broken down, it can get irritated. So by rotating it, it helped with some of those reactions, at least in theory. So the outcomes, so the primary measure was the difference in rate of response between the placebo and the active treatment groups. So at the end, they did another oral food challenge to see if there was any change in their original challenge versus now. So the response to treatment definition, the low dose group, in order to be considered to have a response, they would need to get up to 300 milligrams without any reaction. So what we talked about earlier in that oral food challenge, we did the increasing doses up to 300 milligrams. So if the low dose group, who was only able to get up to 10 milligrams before, was able to get up to 300 milligrams this time, then that would be considered a response. Now in the high dose group, which if you recall was anybody from 30 up to 300 milligrams, they were considered treatment response if they had an eliciting dose of 1,000 milligrams. So if they were able to make it up to 1,000 milligrams without any reaction, then they would be considered a treatment response. And then they also looked at the outcomes of the treatment emergent adverse events. So you'll see later on the PowerPoint, they'll be abbreviated as TEAEs. And so these were measured by the site investigators. They assessed the causality and relationship of the events to study drugs. So we know that these kids also have some other comorbidities. They have, other allergies, eczema, allergic rhinitis. So it was important to be able to look at these adverse events and determine, are they due to the peanut patch, or are they due to something else? Like, did this child eat something that had peanuts in it, or did they, are they a milk allergy and ate something with milk in it? So they had special site investigators who were in charge of that. And then these site investigators were also blinded to the study drug assignment as well. So when these kids came in, they were not sure if these were the peanut patch kids or the placebo kids. So that helped with the blinding of the study as well. All right, so we're just going to do a little aside here, a quick teaching on confidence interval. And I know that Dr. Estep did this last time, but this confidence interval is pretty vital to this study. So I just wanted to talk really briefly about it. So the statistics glossary defined the confidence interval as estimated range of values, which is likely to include an unknown population parameter, and then the estimated range being calculated from a given set of sample data. So typically, the confidence intervals within 2 standard deviations from the mean. You have an unknown measure, then you can estimate this using the standard error. So I'm not going to go into the logistics of how to calculate that, but just something to keep in mind as we go through the next couple slides on the confidence interval. So our trial did not have a mean that was known ahead of time, so they had to do the standard error in order to figure that out. And then we'll talk about this a little bit more later, how our confidence interval was arranged. But basically, the AR101 trial also used the 15% confidence interval, which was the oral therapy, which that therapy is now, I believe it's FDA approved from what I could read on that. So again, we'll touch a little bit more on that later. I think I'm getting ahead of myself here, but we will get there. And we got there. So our statistics, the lower bound of the 95% confidence interval was selected to be 15 prior to the start of this trial. And this was mainly based on input from the FDA. There are certain parameters the FDA has that they require for these studies. And kind of looking through some of the other studies that have had a little bit more research, like the oral sublingual therapies, they all also use that 15% confidence interval. So in order to prove that this drug was as good as the other ones, we needed to use that 15% confidence interval in order to prove that. So that was kind of why they picked that as their lower bound of normal prior to starting this trial. And then the sample size of 330 based on their calculations would yield at least 90% power. That was assuming that you had a 40% responder rate with the peanut patch. So at least 40% of those with the peanut patch responded was the assumption to get this power. And then at least 10% of those with the placebo had a response, and that would also get us to this 90% power. All right, so let's talk a little bit about the outcomes of this trial. So the adherence rate that we talked about in this trial was 98.5%, which was pretty good for this trial. And then their confidence interval that they calculated for this was 12.4% to 29.5%, 95% confidence. This was with a p-value of less than 0.001. So with this in mind, they established that the primary outcome was statistically significant. That confidence interval did not cross 0. So we are saying by looking at this that there is a response and there is statistically significant. However, when we're looking at the primary outcome of this lower bound of the confidence interval, that 12.4%, crossed that value of 15%. So that's kind of where we run into the trouble here about looking into this study and is this really a statistically significant study? They did do post hoc analysis adjusting for the sites, but this was again not statistically significant. And since this confidence interval crossed that bound of 15, they were not able to do a secondary exploratory outcomes to assess the rest of this trial. So here is a graph looking at the confidence interval. I'm sure we've seen this before, so I hope you guys can see my pointer, but we have here, which is 0, and ordinarily when we're looking at this, we want to see if that confidence interval crosses 0. If it crosses 0, then we can't say that it favors the treatment over the placebo. However, when we're looking at this, our confidence interval is not anywhere near 0. However, when we looked at the analysis of this prior to actually getting the results, they had set that confidence interval as 15, which is laying right there. And you can see that all of them pass over that 15%. So that is definitely something interesting that we will definitely talk about. So the TEAEs, which were those adverse events, the incidence of this was 95.4% in the peanut patch. So 95.4% of those in the peanut patch had some sort of adverse event. And then also in the placebo patch, we have 89% that had. Most of these were due to pruritus, erythema, and site swelling, not as much due to anaphylaxis, which we'll go into a little bit as well. The discontinuation rate was 10.5% in the treatment group and then 9.3% in the placebo group. And like I said, we kind of touched on this already, but the biggest was being withdrawal of consent in these individuals. Some in the actual peanut group had to withdraw or were discontinued due to adverse events as well. So here's our table of potential adverse events or actual adverse events that occurred in these groups. So most of these that you can kind of see are in the pruritus, erythema, and swelling. You have some in the eczema, and then less so for, we have like the eye disorders, the allergic conjunctivitis, respiratory was not, oh my goodness, as high in the number of events either. So mainly skin-related events, which I think would be expected considering you have patches on your skin. There were a couple serious and severe events related to the patch, and then the rest were moderate to mild. So they're just reclassifying the events that are above up here into whether they were mild, moderate, severe. And then those related to the patch leading to temporary discontinuation were 16%. So that was 26 number total in the peanut patch group. And then those going towards permanent discontinuation were only 4. So 26 only leading to temporary and then 4 leading to permanent discontinuation. We can talk a little bit about the anaphylactic reactions because I think that's really important to talk about since that is the highest risk that we run in these trials. So they define their anaphylaxis as the presence of cyanosis, hypoxia, hypotension, confusion, loss of consciousness, or incontinence. So they did have a total of 26 cases of anaphylaxis in 23 different participants. 10 of these reactions were determined to be secondary to the treatment. So the other cases of anaphylaxis, they didn't go into a whole lot of details to what caused them, but they were determined not to be part of the patches that caused it. So of the 10 that were secondary to the treatment, 6 of those had to be treated with epinephrine. And then there was one participant who was just really unlucky and had 3 anaphylactic reactions during this trial. But he or she completed the trial. A little crazy that their last anaphylactic reaction, I think, was at day 356 or something around that time. But most of the other anaphylactic reactions occurred within that first month of the trial starting. Okay, so going again into like the statistical significance of this. So this study did not meet the goal in that it was statistically significant, but it didn't meet that confidence interval. And I know I've said that multiple times, but that was kind of the main theme that came from this trial was that, yes, it is statistically significant, but we did not meet our pre-specified parameters. So what do we do with this trial? And that's kind of hard to say. Dr. Nguyen and I had a lengthy conversation about this as to what can we do with this. So like I said, statistically significant by traditional definition because it doesn't contain, let's just say 0, not 1. However, that lower confidence interval crossed that threshold of 15. So technically we can't say that the criteria was met for a positive research trial at this point. So going forward, I think one of the things that will need to happen is that there needs to be a more defined response rate cutoff, because from what I could see, there wasn't a ton of science behind this 15% cutoff rate. It's just kind of been used in previous studies. So we were kind of using that as the kind of the benchmark to compare to the other studies. So I think there needs to be a little bit more research into like whether this 15% is actually truly. And then ultimately this treatment did show some response. It's a long-term investment. As we could see, it's a year long. And I know some of the oral trials go on for years at a time. So that's just something to keep in mind as well. And then you have close monitoring at the beginning of this trial for adverse reactions. But I would say the same is for sublingual and oral therapies as well, since you're actually eating or taking that in. All right, so looking at our Carilion population, and is this generalizable to our population? So I know that we have a ton of peanut allergies in the Roanoke Valley. I've seen them in outpatient. I'm sure everybody else has too. And this is slightly generalizable to our population, but kind of what we talked about earlier is that this population only covered mainly Caucasian race. It did not have a large majority of any other races. So we can't necessarily say that that's going to work for all of our patients based on that criteria. And then they also had to exclude those with severe anaphylaxis. So our kids who really are at the most risk of having anaphylaxis due to a contaminated peanut product, because all our kids are like, oh, who cares? We'll eat a may contain peanut product. I'm sure you've all seen it before. So this trial may not be generalizable to them too, because it's a high risk in order to use this epicutaneous therapy on these kiddos. And then it's not necessarily ideal for anybody less than 4. And then it wasn't studied in anybody greater than 11 years old, at least in this trial. I know we talked about the other trial that was 6 to 11 years old that was good moving forward. So just something to keep in mind as we talk about future therapies for our patients. And then the other thing that I wanted to talk about in this trial is that there was a significant number of these TEAEs throughout the trial. That's a mouthful. So I think it was a lot more than what the authors were originally expecting, because this epicutaneous therapy was supposed to be side effect friendly. Granted, we didn't have as many systemic side effects based on the numbers that we looked at before. Most of them were cutaneous in nature, which we already talked about makes sense. But definitely a significant, almost all of the participants had some sort of these adverse events. And then did this lead to a inadvertent unblinding of the participants? So if you have a child who has this patch on and then they're getting redness around the area, the parents may be sitting there thinking, oh, does this kid have the treatment group because they're turning red, because they know what they're in the trial for. So just something to think about as we're talking about the double blindness of this control trial. And then vice versa, you could have somebody who thinks that they have the treatment patch, but they're just getting a skin reaction from this Band-Aid-like material on their back. And then all of a sudden they're thinking, oh, I have the treatment patch, and just, unblinding on both sides. So definitely something to think about with regards to this trial. All right. So overall picture for this, we don't have a cure for peanut allergies. I don't know that we're necessarily on track to find a cure at this point, but could this help prevent accidental ingestion induced anaphylaxis? We already talked about the kids who eat the may contain peanuts, and parents are terrified that, oh my gosh, what if they have peanuts in them and my child inadvertently eats it and then goes into anaphylaxis. So I think the overall goal of this is not necessarily to find a cure for the peanut allergy, but to help prevent these anaphylaxis reactions, or just lessen the severity of anaphylaxis in these kids. So hope maybe they wouldn't need epinephrine and could maybe just take some Benadryl or something like that. And then there is some other research going on that talks about raising the eliciting dose to greater than 300 milligrams might prevent anaphylaxis in products that may contain peanuts. So essentially what that's saying is that if you can reach that 300 milligram oral challenge before getting any adverse side effects, that would theoretically prevent you from getting or going into anaphylaxis from a minor amount of peanut product in a candy bar or whatever they're eating. And they're saying that this could prevent as much as 95% of potential reactions. Like I already said, multiple methods to address allergies at this point, ongoing research to find a cure. Epicutaneous methods do have promise because it's easy to use at home. You don't have to think about them. It's just sitting on your back. But the high side effect profile might be a hindrance to this being effective in the long term. So whether this does become FDA approved or not, this, it has to be a decision between the patient and the provider, talking about the risks and benefits of all these treatment options, doing the oral or doing the epicutaneous, the sublingual. All of these are really important to talk about these side effects and results. Right, so these are my references, and that is basically the end of this trial. So I would love to hear if anybody else has any thoughts on the effectiveness of this and whether they think that this is something that has a future. So feel free to chime in.
Based on the clinicaltrials.gov website that they are looking to do 2 additional trials, one to follow both the placebo and the treatment group for a longer period of time, over 3 years, to see if maybe they just needed a longer period of treatment to really show improvement and desensitization. And they're also doing another study looking at a younger age group of 1 to 3 years. So it's an evolving field, and I think, and then the other thing is the oral immunotherapy that Jackie kind of alluded to, that is now FDA approved. So that study was done after the one that Jackie went over, and it did show some effect. So that one is actually approved for certain centers and for certain allergists to prescribe, but it's very intensive, as you can imagine. And so it is definitely an evolving field, and it's can be hard, I think, in something that is constantly evolving, to kind of figure out how do you what do you compare it to if there's nothing else there that's proven to work for these patients. So I think that's probably a little bit of the trouble that we kind of ran into in interpreting these results, as did the authors of the study.
Oh my gosh. Absolutely. Thank you, Dr. Nguyen, for giving your input. And I also want to thank Dr. Nguyen for being my advisor for this. She was super helpful, so I appreciate it very much. Anybody else have any comments or anything they'd like to add to this article?
Hey, Jackie.
Hey, Dr. Ward.
I'm impressed with you picking this one. It's a hard one to read and hard one to interpret. Going back to your randomization, I don't know if standard is the right way to word that. They went about it a little differently. They did like permeated blocks, which is a little bit different than, say, flipping a coin. There can be some bias with that. So for what it is, it's grouping your randomization, saying that they're going to take blocks of 4 patients and randomize that one group. So there can be bias with that if the physician knows that there is a block randomization, they've treated 2 patients, they've had some of these subcutaneous findings, that can kind of create some unaccounted for biases and affect the results. And that's typically done with smaller studies when the numbers are, say, less than 100 or so. It's interesting that they include it with this trial because it was a little bit larger. I wanted to see what your thoughts are with the FDA weighing in on this, and why they included a confidence interval of 15%. Did you have any thoughts on that?
So I spent a whole lot of time, I'm talking like hours, trying to figure out where they got this 15% confidence interval from. And I felt like I was just going down a rabbit hole because basically these other studies are using this 15% confidence interval, but I couldn't quite find a actual reason for why that 15% was chosen. And from what I could understand, basically our trial was like, okay, these other trials are using this 15% confidence interval. So if we're going to prove that we're as good as these other therapies, then they would use the 15%. But it was not an easy find to figure out where this came from. I don't know if Dr. Nguyen was able to find anything else, but I was going down a rabbit hole with that. So those are kind of my thoughts on that.
Well, what's interesting is so the FDA is made up of the top of the top for sort of approval for your clinical trials, especially because this was, I believe, it's a phase 3, so they compared to placebo with this trial. And there's a recent study. It was kind of a simplified way to look at the probability of having just random chance affect your results. And it's described, the example is an archer. So if you take an archer who says that they're very skilled and you let them shoot a bow and arrow, and the likelihood of them to hit their target, if they're lying to you and they're not a skilled archer, they're unlikely to hit the target, whereas a skilled person would. But if there's random chance, say you let that archer shoot a bunch of arrows at once, you're more likely to find something statistically significant with your results. My thoughts with the FDA, and I think this is why it was probably published in JAMA, because their studies, essentially the way they worded it was a negative study, is the FDA, if they were going to approve this, they had to really make sure that there was no random chance that these results were, because of that they just sort of like the archer that shoots a bunch of bow and arrows. Because one thing that you also have is that you have some harm events here. And it was, you had mentioned how many patients had these adverse events. And if you do an analysis on that, I just plugged them in as you were going through with a calculator. I mean, 1 in 4 patients, you give this treatment to 4 patients, and 1 in 4 will have a harm event. So it's pretty significant. So my guess is the FDA set this is a very tight margin. And if there's any question about it, then they're not going to necessarily approve it. More studies need to be done. That's one thing. And then the other thing I was going to talk to you about is the post hoc analysis. And this can go out to anyone who didn't read the article. But you'll see this sometimes with studies, is they'll do a post hoc analysis. And I wanted to ask, I guess, the group, what is the utility in a post hoc analysis? What are we trying to achieve by doing that?
From what I understand, the post hoc analysis is basically kind of analyzing after the fact. So I'm not very familiar with it, but my assumption was that you kind of use this to tweak your statistics at the end to see if you turn it another way, that maybe you'd get something statistically significant. You can correct me if I'm wrong. I'm not a statistic guru by any means, so.
Yeah, you're kind of right, but I would caution that though. So what I'm kind of asking you is how you should interpret post hoc analysis, and it's more so that the authors may start just really beating through their data and trying to find something that is publishable, depending on all the tests they've run on there, or the models. You had mentioned some of these complexes I've never even heard of either. To interpret a post hoc analysis is really more for hypothesis generation for another trial. So you'd be very cautious with the post hoc analysis and just take it with a grain of salt, and it would more so spur on another study. And then there's another point I wrote down. Oh, intention to treat analysis was done. The table 2. Do you understand what that means when they did an intention to treat analysis on their data? It was table 2, the first one that they ran, where they put the forest plot.
The one on the confidence interval that you're talking about, I think I have that in here.
It's table 2 where they did intention to treat analysis. Then It's they put the confidence interval, and then beside it, they did a forest plot.
This one that you're talking about?
Yes.
Okay.
On my computer.
So you're talking about the intention to treat right here.
Understand
about
that. And you may not, but it's
no.
So you see, they did several types of analysis. The intention to treat is when you randomize the patients to one study arm. So say you randomized them to the peanut patch, and they just decided they weren't going to do it, and they would still keep them in that group when they analyze the data. Potentially, it's more so when you have major interventions, like, you know, this patient gets a surgery versus not a surgery, but you keep them in the group of which their intention to treat is. And what that does is it at least cuts down some potential confounding that the authors may do, either consciously or subconsciously, that they would come back and reanalyze that in a different arm. So they may pull them to the other arm of that where they didn't get treatment, and it can affect your outcomes. So that's one way. It's a cleaner way to analyze a randomized control trial, is to do an intention to treat. So they ran that analysis, and it was, for the most part, pretty positive. But again, it didn't meet the FDA's criteria. And then, so intention to treat, there was something, so another point I was going to make for table 1, your demographics, some of the descriptors there. So you're always, when you read these trials, you're always trying to find things that can influence the statistical outcome or the clinical outcome, which they said was not, statistically it met criteria, but clinically it did not, according to the FDA. There may be other factors that we don't account for that influences, and you mentioned some of these as well, that influences your data and throws it off. And this is why it's really hard to really account for all of these things. But there may be certain variations of diet that some of the kids were having, because there were some responders who got placebo and they actually had a promising outcome. There may be something in the immune system level. I mean, there's all sorts of things. And then you're taking this study also across the pond, the Australians, the Canadians. There may be some other things that we can't really think of that may skew the data a little bit. So it's not to say, I mean, it's almost like this study was, it is kind of a negative study, the way they clinically worded it, which is good, because I could see these authors taking this and just running with, if the FDA wasn't involved, and running to another journal and they publish this as a positive study. That could easily happen. But there may be other confounders here that they're not able to account for, just with the limitations of their trial, that's throwing the data. And maybe this is a positive thing to do, like Dr. Nguyen was saying, especially with the oral therapies. There may be other things that we just can't see or know that's throwing the data off. I think that's all I've got.
Well, thank you for your input on that. I really appreciate it. So
I'll say this was a challenging one to read, but I applaud you for doing a randomized control trial and going through that. There are very much limitations to those, and you just kind of have to tease it out. But I like your presentation for the confidence interval, the importance of that. But overall, good job.
well, thank you very much. All right, guys. Well, I think we're just about out of time. So I'm gonna let everybody go. I appreciate you guys joining me today.